Incidence of class 2 is more than 20% in the US, but more than 40% of the population in Europe. The best treatment corrects the bite, but also improves facial aesthetics and ends up with a better airway. Especially if we want to get a nicer face and a better airway, in a lot of cases we should advance the bony chin. And of course we do this in adult cases by orthodontic surgery, but we try as an orthodontist in growing children to stimulate growth of the mandible. But how does the chin grow forward? In fact, it does not grow forward. There is absolutely no bone apposition at pogonion. In fact, the chin is displaced forward by three mechanisms. The first is true mandibular lengthening, and it should be defined as we see on this graphic. For each millimeter of lengthening of the mandible, you get forward projection of the chin by 1 millimeter. You can't measure this accurately in 2D, but in 3D, we can register both mandibles before and after growth on the chin and exactly measure the true mandibular lengthening. The second mechanism of forward growth of the chin is glenoid fossa modeling. Ideally, the fossa should remodel forward, but how much the fossa is remodeling and displacing anteriorly is difficult to quantify. And it doesn't interest us. What we are interested in how much the condyle moves forward following glenoid fossa modeling. And for each millimeter of forward displacement, we get 1 millimeter more chin. Does it really happen? Yes, of course. We see here a case where we see in magnification how the whole fossa has been coming down and forward, moving slightly the condyle forward. I did some tracing, so it's better for you to see from the room. And you see that as a resultant of this, the condyle slightly is displaced forward and downwards. And finally, the third mechanism of chin advancement is mandibular rotation. Of course, anterior rotation results in forward displacement. For each degree, we get 1.1 millimeter more chin, and in the opposite direction, posterior rotation will result in less chin projection. We have no time today, but we developed a new protocol to exactly measure true mandibular rotation. And as we will see in a number of examples immediately, rotation has a very important impact on the forward displacement of the chin during growth. And we can measure this now very accurately in 3D. So finally, we see that during growth, chin is displaced forward by true mandibular lengthening, glenoid fossa modeling, and true mandibular rotation. Now, we as an orthodontist, we try to accentuate, to amplify these three ways of growth of the chin by different appliances that we should divide in devices that really push the mandible forward and others that don't. Of course, we should only look at these appliances. So one of these appliances, maybe you use them, most used in the United States, the Herbst appliance. The principle is that we insert a so-called orthopedic appliance to move the mandible forward. We bring the condyle out of the fossa, we push the chin forward. At day 1, we place the Herbst appliance. And then we cross our fingers and we hope that this will result in more growth of the mandible and a longer mandible at the end of treatment. But how does it really work? The day you insert your Herbst appliance, because of the connectors, the patient can only close the mouth when he advances the lower jaw by contraction of the pterygoid lateral and medial muscles. So this is at day 1, the day he goes out of your office. And what is happening from the first day after propulsion? Because of the propulsion, you get stretching. Stretching of the digastric muscle, the suprahyoid muscle, but you also get stretching of the temporal muscle. And these muscles are acting as big rubber bands and from day one try to pull the mandible backwards. But the mandible can't go back because the Herbst appliance keeps them in propulsion. The continuous elastic traction by temporal muscle and suprahyoid muscles are going to apply distalizing forces to the upper dentition and mesializing forces to the lower dentition. And we are used in the literature always to look at the incisors. And look what happens. Okay, the lower incisors, they procline, and the upper incisors, they retrocline. Yes? But what we don't look at is that for each millimeter that your lower incisors is proclining, and for each millimeter that your upper incisors go back, your condyle goes 1 millimeter back. And within 2 months of treatment, the condyle is completely back in its fossa again. So this is what's really happening with conventional Herbst appliance. And of course we have conventional growth, about 2 millimeters, that will result finally in a forward growth, a forward displacement of the bony chin by 2 to 2.5 millimeter. But is this growth stimulation? Did we really do an orthopedic treatment? Now, based on the literature, we don't. In a review that I wrote together with Dr. Profit in 2015, he wrote, the data do not support the idea that the orthodontist is growing mandibles. There is no evidence available that we can stimulate growth of the mandible. And we did a research, a non-systematic review of the literature of the last 30 years. And what we found out is that in more than 300 papers, finally we come to the conclusion that gonial angle is not modified and that the chin is moving 2.4 millimeters forward as much as it would do without a Herbst appliance. And what we see, of course, is proclination of the lower incisors 6 degrees and retroclination of the upper incisors. And it's our hypothesis that the bed skeletal changes are a consequence of dentoalveolar compensation. And that's why we had the idea to develop a new Herbst appliance. So this is a Herbst appliance with a tooth-supported metal frame in the upper jaw and with 2 custom-made bone anchors in the lower jaw that we can insert under local anesthesia. What is the difference with a conventional Herbst appliance? Well, also when you insert this appliance the first day in your office, the patient can only close the mouth when he contracts the muscle and forces the mandible forward in a propulsed position. But now the difference is that we have a bone anchor in the bottom, so we get only distalization of the upper dentition by the tension of the muscles. This distalization will also result in a posterior displacement of the condyles. The difference is now that if this happens, you get a bigger sagittal overbite. So when we see this, we are going to increase the length of the connectors. So to avoid distal displacement of the condyles as you have with conventional Herbst appliances, we need for compensating this distalization by lengthening the connectors between the upper frame and the bone anchors. So about 2 to 3 times during the 10 months of treatment, we have to lengthen the connection between the upper frame and the lower bone anchor. And as you see, we put 1725 in an 1825 slot to keep the upper incisors forward so that we can fully advance the lower jaw. And if we keep the condyle 10 months out of the fossa, then we see things happening that we have never seen before. Lengthening of the mandible, growth of the mandible, and forward projection of the chin. Now you will say, Hugo, this is just a graphic of another illustrator. No, it's a graphic that I made based on a real patient. This patient. So we go back. How did we get there? So this is the end of treatment. You see the condyle is perfectly seated before and after treatment. And we see a tremendous growth. How did it happen? This is the boy, 14 years old, width 10 millimeters, hypodivergent. CBCT before treatment, and 2 months after removal of the Herbst appliance, which has been in place for 10 months. Tung Wen at Chapel Hill University, who is well trained in this, is going to do the registration. But every time we start checking if the condyles are well seated in both CBCTs, and then Tung is doing the registration for me, he's the best in that, and so we get 2 types of registration. For each patient, registration on the anterior cranial base on the left side and registration on the chin on the right side. And now we are going to measure the 3 ways of growth of the chin. In the first place, we look how much the condyle moved forward following modeling changes in the glenoid fossa, plus 0.08 millimeters. And then we measure the lengthening of the mandible. And in this boy, the mandible lengthened 5 millimeters, true mandibular lengthening, as we never measured before in 2D. And finally, we got an anterior rotation of the mandible multiplied by 1.1, so we can make the addition, the sum of these 3 values, 0.8, 5.0, and 1.3 multiplied by 1.1. So in theory, we should have 7.2 millimeter forward displacement of the chin by growth. And this is exactly what we measure on the superimposition, the registration of the 2 CBCTs on the anterior cranial base. 7.2 millimeter forward growth of the chin. And we know where this is coming from. You see it better when you make a sagittal slice, a mid-sagittal slice, and you measure 7.2 millimeter. And why is this result so much better than we have ever seen with conventional Herbst appliance? Because we got retroclination of the lower incisors. No proclination, we get always retroclination. So we keep the condyles for a longer time out of the fossa. And so finally, because we advanced the bony chin more than 7 millimeter forward, we get nice improvement of the face, but most of all, if we look at the airway, we see that the airway doubled in volume from 16,000 millimeter to 33,000. And also the minimal sections became double as big. So what is the difference? This is the graphic based on this patient that illustrates what you really do with bone-anchored Herbst. And in contrast with the conventional Herbst is only giving bone projection in the chin forward, which is related to normal growth. Let's have a look at the bed case. Open growth patient, class 2, 11 years old. We did the same treatment, CBCT before and after. Both condyles are well seated. Registration on the anterior cranial base and registration on the chin. Now we got a favorable forward displacement of the glenoid fossa that moved the condyle 1.2 millimeter forward. We can measure this very accurately. And we got an amazing lengthening of the mandible, 6.4 millimeter lengthening by growth of a mandible. Who can believe this? But the bad thing is that we got 2.5 degrees posterior rotation. So only based on fossa modeling and true lengthening of the mandible, we should have forward growth of the chin by 7.6 millimeters. But unfortunately, we got posterior rotation. And if we make the sum, we lost a lot of these good effects of the growth by posterior rotation. So why I show you this case is that we learned from this that if you get huge lengthening of the mandibles like you get here, you need a lot of expansion of the upper dentition, what we didn't do in this case. So you see that look at the lower incisors, on the top in the beginning, on the bottom at the end, how much they retroclined. But what we did wrong was that we didn't expand. We got edge-to-edge occlusion and crossbites in the canines. That amplified the posterior rotation of the mandible. And once again, huge retroclination of the mandible. But because we didn't control the posterior rotation, we got not a favorable result on the profile. So we learned from this case that nearly in all cases you need, together with AP correction, to do expansion. And we have 10 months to do that. So we do a slow expansion for 3 months and we keep it in retention for 7 months. Fantastic to combine this with the AP. So this is a minor case of a boy, 14 years old. You see it's very critical transversally for the premolars. So in this case we did it correct and we combined forward displacement of the chin with transverse expansion of the upper dentition. Good positioning of the condyles before and after treatment. Registration on the anterior cranial base and on the chin. Here we were very unlucky. So the modeling in the glenoid fossa sometimes goes in the wrong direction. So we kept the condyle out of the fossa, but here we got a remodeling backwards. So that's something we cannot control. We lost 1.2 millimeters of chin projection because of modeling of the glenoid fossa. We got a lengthening of 4.3 millimeter of the mandible and we got a slight anterior rotation of the mandible. So finally, because of the bad fossa modeling, we only got 4 millimeter of forward growth of the mandible. But what we did better compared with the previous case is that we did expansion. And you see how much the upper dentition distalize. Look the second molars, how much they distalize. Look at the canines and the premolars. But now we combine this with expansion. And this will reduce and limit the posterior rotation of the mandible. And you can see it in the case here. So you see that the premolar occlusion laterally was critical, but we did a lot of expansion during the forward growth of the mandible. Profile changes before and after. In cases where we have retroclined upper incisors, and especially in cases where you start with proclination of the lower incisors, like in this girl, 14 years and a half old. Proclination of the lower incisors. If you want to bring the lower jaw forward, you have to start with proclination of the upper incisors that we do in Europe, always with removable appliances. One day I will convince also you here in the US to do that. It's easy, it's fast, it's cheap, and it's very predictable. So we do 4 months of proclination of the upper incisors, and then we put a Herbst appliance. Before treatment, 14 years and a half, 2 months after removal of the Herbst appliance. Condyles perfectly seated. Growth, anterior registration on the anterior cranial base, registration on the chin. What did we get? No modeling changes in the glenoid fossa. We got a growth of 4.4 millimeter of the mandible, but we got a very, very favorable anterior rotation of 1.7 degrees. Multiplied by 1.1, it gives us 1.9 millimeter more chin only by rotation. But isn't it amazing? 6.3 millimeters of forward growth of the chin, forward displacement of the chin, thanks to these 3 mechanisms of chin production. So huge changes that we have never seen before and that you could better see in the sagittal slices, 6.3 millimeter. And we got a very nice anterior rotation of the mandible because we did a lot of expansion during the AP correction of the growth of the mandible. And once again, no single case we had so far. We have more than 90 cases in our study now. In all cases, retroclination of the lower incisor. Can you imagine what would have happened if you would have placed a conventional Herbst appliance? There is no bone labially from the roots of the lower incisors. So we always get retroclination. And because we get retroclination of the lower incisors, we keep the condyle out of the fossa. And then we get growth changes. Changes in the profile before and after. And finally, another case that illustrates that you need a lot of proclination, especially in class 2 division 2 case. But why is this case so special? The boy is 15 years and a half old, CVM5 for those who like, with 7 millimeter vertical deep. So again, with removable appliances in 4 months' time, we procline the upper incisors. The boy is 2 meters high. So we have the CBCT before and after treatment, condyles well seated. We do the registration on the anterior cranial bed, and look what happened on the left picture. How much growth we got in a 2 meter high boy, 16-year-old. Who can believe this? And you see how much growth we got in the superimposition. And again, we had bad luck. Look at the modeling in the glenoid fossa. Posteriorly directed modeling. So the condyle moved backwards. And despite that, we got a lot of growth of the chin. So 0.7 millimeter backward and downward displacement of the condyle due to glenoid fossa modeling. But we got an amazing increase of true mandibular lengthening, 6.5 millimeters in a year. Who can believe this? And we were lucky, rotation, just not posteriorly, 0.3 anteriorly. And if we make the sum of all these values, we come to 6.1 millimeter. And that's what we measure at the level of the chin. And once again, if we look at the slice through the superimposition on the chin, again, a huge amount of retroclination. Why does it retrocline? We have two explanations. First, because we all the time push the lower incisors against the molar. It gives some pressure from labial, and from the lingual side, we get less pressure from the tongue because we bring the jaw forward for 6-7 millimeters. And a lot of these cases now, if the skeletal correction works well, we can treat these patients just with aligners. Yesterday evening, I had a quick pizza with Tung Wen, and he was impatient to see me yesterday because he's doing the registration of our cases. And he said, Hugo, I have the last case that you sent to me. Growth stimulation of the chin, 9 millimeters in 1 year. I don't have the pictures. He's going to show them to you Monday morning from 8 to 9. But now the question is, how can we explain? How can we explain that suddenly these mandibles, they grow like crazy, where for 100 years we are trying to stimulate the growth of the condyles, and there is absolutely no evidence that so far we were able to do that. So what's the difference between this approach? Well, the only difference is 2 bone anchors in the lower jaw. And the 2 bone anchors in the lower jaw eliminate all dentoalveolar compensation. But this doesn't explain from a biological point of view why is this mandible becoming longer. Well, I can talk half a day about that. But based on our research for more than 30 years now on dentofacial orthopedics, we believe that the reason why these mandibles grow so much is that on one hand, your connector of the Herbst appliance is pushing the bony chin forward. And while you do that, you stretch the temporal muscle. And this temporal muscle acts as a big rubber band on the coronoid process. And so you get a couple of forces, and you learn during your training that this is the most powerful force system that you can get. 2 forces, the same line of force, the same magnitude in a different sense. And this gives huge tension and compression zones in the gonial angle. So we strongly believe that these amazing lengthening of mandibles, that we get them not by condylar growth stimulation. So many animals have been sacrificed and killed to slice their condyles to try to find some growth stimulation. There is none. We strongly believe that the only possible explanation is modeling changes in the ramus, bring the whole ramus backwards and lengthening the mandible. What do we take home? Well, if you take home one thing, one only thing, then it's this. If you put a Herbst appliance with 2 bone anchors in the lower jaw, then you don't get proclination, you always get retroclination. And it is the proclination of the lower incisors that is responsible for the complete shift back of your condyle, within the first 2 months of your Herbst treatment that you do in your office. If you control proclination of the lower incisors better, you transform it in retroclination, you keep the condyle 10 months out of the fossa. And then the temporal muscle is pulling on the coronoid process and is pulling the ramus back and is giving bone modification, bone modeling in the gonial angle. And this is based on a lot of research we've been reading from Dr. Enlow. Beautiful. He predicted this already 40 years ago, but it brings us too far. But we have to realize that if you don't use bone anchors in the upper jaw and you use a dental supported frame in the upper jaw, you have to realize that you get distalization of the upper molars. You have to compensate for this first by lengthening the connectors 2 to 3 times during the 10 months of treatment. And second, you have to avoid that the incisors on the top retrocline by putting a rectangular wire with some reversed curve in it, and then you keep the condyles where they have to be, out of the fossa. And if you do that, you get growth changes of the mandible. And yes, we get lengthening, true mandibular lengthening we've never seen before. Glenoid fossa modeling is a minor player in the overall success. We only see small relocations of the condyles, but sometimes in the wrong direction. And we can't really say now, after the first 90 cases, why in certain cases the condyle is moving forward and in others backwards due to remodeling of the glenoid fossa. But what is much more important is the vertical downward modeling of the glenoid fossa, which is going us to help to get an anterior rotation of the mandible with a bigger increase of the projection of the chin. The chin advancement is in a very big amount influenced by rotation. True mandibular rotation can increase projection, but it can also reduce projection, as we have seen in the second case, the girl that I showed you. So that's why we think that we have to do a lot of expansion during the advancement of the lower jaw to reduce the posterior rotation of the mandible. And last but not least, the bone anchors. Please don't try it. So the loading of the bone anchors is huge. The forces acting on these plates are immense. So for this reason, we developed new bone anchors that are patient-specific made in the strongest titanium that is available. And even then, you have to know some practical tricks how to avoid that these bone anchors get mobile. We have 93 cases included in our study, and so far we lost 1 bone anchor, only one. So this is beautiful because we make them patient-specific with surgical guides for the surgeon, so to make it straightforward and that the surgeon is placing them exactly at the place for which we have designed them. If you have some questions, and I can imagine that you can have some, you can send them to the mail address of our small research team in Brussels, and I thank you so much for your attention.
Thank you so very much, Dr. de Clerck, for this very thought-provoking presentation. We do have time for a couple of questions, and if nobody in the audience speaks up, I will, because I have some questions for Dr. de Clerck. Do we have any questions from the audience?
Yes, there.
Okay.
Is there a mic? Can you?
Are there age implications, recommendation of your protocol?
So we have always been taught that orthopedics has to be done the youngest possible. And the later you do it, the smaller is the effect. But here we are not acting on condylar growth. We are acting on bone modeling. And we know that bone modeling is going on much longer than normal growth of the condyles. We need, the best age for us is between 13 and 15. And the reason for that is that we want to have the second molars fully erupted because we get intrusion of the upper molars because of the continuous pressure on the first molars. So ideal age for a lot of reasons, 13 to 15. Yeah.
Have you used it in adult patients at all?
Have we used it in adult patients? No. So the oldest we do is 16, 17 years. We didn't do longer, but it wouldn't surprise me if it works at 16, 17, it could, but the oldest are 16, 17. That's pretty old, huh? Compared with what we are used to do in dentofacial orthopedics.
Those of you that are walking out, we still having some very interesting questions. Please walk out silently and quietly so we can enjoy this session. More questions from the audience? Yes, please.
If we use conventional Herbst for veneer, we all know that there will be a mandibular length increase. But the problem is that in the long term, the increase was just temporary. So temporary acceleration of the growth, and later, untreated, when we compare it with the untreated sample, there was no difference in the mandibular growth.
Yeah.
The important question is that, is this effect is also effective after the long term?
Yeah. I can be short. So the question is this maintained long term? The answer is, I don't know. Good. And the reason for that is that we started our research January 2021, and so we have 95 cases in. The only thing I can tell you that hardly no class 2 elastics are used in any of these cases after we go to fixed appliance or liner treatment. But the long term, no, we have to wait.
Yeah, my question is, you use TIDE, right? What's the size of TIDE?
The size of?
TIDE, mineral, the mini screw. What size the mini screw?
Yeah, we don't use mini screw. I cannot believe this, that you can do this with mini screws. A lot of trials have been done in the past. For sure you cannot put this connected directly to a mini screw. I can't believe it. You can connect a mini screw to a canine and then hoping that you get less proclination. But you need mini plates and you need them printed in the hardest titanium that is available. So with mini screws, so the plates are fixed with 3 screws to the bone. Yes, so it's a mini plate like a borrowed mini plate, but the titanium is much harder than conventional mini plates because the shocks and the loading is so hard during that year that you absolutely need much stronger stuff. But I cannot believe it that you can do this with a mini screw. It's impossible.
Thank you.
And the kids in Belgium are more well-behaved than the American kids because in Belgium in 10 months they don't break that Herbst any time. So how much breakage are you really keeping the condyle in a protruded position if your patient in 10 months has broken the Herbst 3 or 4 times?
Yeah, so the only thing I can say is that for so far we lost 1 patient about the bone anchor. So then the other issue is of course on the top, so the frame, and indeed it's a big issue. We did a lot of research. Originally they are 3D printed, but the nightmare is that in a lot of cases you can't get them off after anymore. So it's a very big delicate balance that we have to find to have a frame which fits good enough not to get loose, and on the other hand that we don't need an hour at the end of treatment to cut them in pieces to take them off. So we have found some balance in that. But the bone anchors so far, thanks God, they stay stable.
And this is certainly a very intriguing presentation, and in the light of the evidence-based symposium that the Italian Society is planning for next year, comparing class 2 and class 3 options, that's very exciting. But for us, as clinicians, when should we expect to see the results of this research publication published so that we can read about it?
Yes, so now we have the first, from the 93 that are included in the treatment, in the study, 35 are completely finished end of fixed appliance treatment. The problem is that they have been set up over the 3 years during the development of the system. And we continuously made changes in the design of the frames, the design of the bone anchor, the surgical procedure, the orthodontic procedure. So the 93 cases are not homogeneous patients, but we have now already sufficient data that we will be able soon to publish the data, and we are doing the statistics on this moment. So it gets there. So it will be very soon, yes.
Any last questions? We have time. Do you want to get the microphone, Dr. Bajastan? Thank you.
Thank you so much, Lucy and Dr. de Clerck. Just wanted to know if you have untreated cases too in your study to compare, you know, treated versus non-treated patients, and like the kind of relationship of the growth of the mandible with your Herbst appliance?
Yes. So thank you for your question. The answer again is no. And the problem is that the measurements that we do, the accurate measurements of true mandibular lengthening, true rotation, and glenoid fossa remodeling, we cannot make them accurately in 2D. So if we want a control group which is not treated, we need 3D material from the same age of patients, the same group of patients. We don't have it. So the only thing we can do for the moment is compare our group with groups treated with a conventional Herbst appliance, from which we have now already a couple of studies. Lucia also published one. So that's the only thing we can compare. But we don't have control group of untreated class 2s of the same that are comparable. And that would be the best, of course. But we don't have this material yet, and we can't find this data in 2D databases.
So we still cannot say how much of the growth was actual growth of the patient
Sure.
due to genetics?
Sure.
Or...
Yeah, we know at least from 2D studies that you may expect 2 to 2.5 millimeter forward growth of the chin. So if we find 7 or 7.5, we had 5 growth stimulation. That's the only thing we can say. But we cannot get all the details only from 2D studies. But for sure, if I say that the chin is growing 7 millimeters forward, you have to take into account that 2 millimeters at least are from normal growth.
Thank
so
you
that's
so
correct.
much. Yes.
Thank you so very much for the very interesting presentation.